Hello, and welcome to One World, One Health, where we chat with people working to solve some of the biggest problems facing our world. I'm Maggie Fox. This podcast is brought to you by the One Health Trust, with bite-sized insights into ways to help address challenges such as infectious diseases, climate change, and pollution. A One Health approach recognizes that we're all connected: animals, plants and people, and the climate and environment. Antibiotics and antivirals can make the difference between life and death. But they're not working as well as they used to because the bacteria and viruses they fight evolve fast. They can become resistant to drugs and turn into what we call superbugs. These drug-resistant infections kill more than 1 million people a year, and many are children. 1 in 5 of those who die from these infections are children under 5. Nearly 7 million newborn children catch these infections globally every year, and more than 500,000 die from them. And the effects go beyond just life and death. Imagine a toddler kept isolated for days or weeks on end to protect her and the other children. Imagine the despair of a mother who can't take care of her own baby in the hospital because she has other children or a job or is just too poor to take a cab there. In this episode, we're chatting with Dr. Heather Finlayson, a Pediatric Infectious Diseases Specialist at Stellenbosch University in Cape Town in South Africa. She deals with these types of problems every day, and she's got deep experience treating infants and children with infections, especially infections resistant to antibiotics. Heather, thank you so much for joining us.
Hi, Maggie. It's great to be here today.
Heather, this is heartbreaking. Such delicate newborns can sometimes be born infected. How can that happen?
Well, Maggie, when you are born from your mother has these bugs on her, and we know that lots of mothers now may be colonized with these resistant bacteria. So as they are born, those bacteria get passed to the babies, and more often now we are seeing resistant organisms very soon after birth. So usually resistant organisms would be after they'd been in hospital for at least 48 hours. But now, because of resistant organisms being far more common in the community, babies can now be born with these resistant organisms.
Can we explain what being colonized means?
So it just means that we all have bacteria on our bodies that we carry around us, and they are good and bad bacteria. We've got bacteria in our gut, and bacteria are very important to protect us at times, but they can sometimes be resistant. So they sit on the mom's skin or in their gut and not causing any problems. But when the baby gets born, because the baby is much more susceptible to infections, they actually may cause infections in the baby.
And my understanding is that newborns don't have their own population of bacteria, their own microbiome when they're born. So there's room for the bad bugs to move in and just take over because there's no one else in that space.
Yes, exactly. So babies get their bacteria and their microbiome from their mothers after they get born. If you're born very prematurely or if you're born by cesarean section, then you may not be colonized yourself with those good bacteria from your mom. And then, of course, in the hospital, we all think hospitals, wonderful clean spaces, but there's lots of bacteria that live in the hospital, and particularly resistant bacteria that might be kind of lurking in the corners. And the longer the baby stays there, the more likely these resistant organisms will become part of their microbiome or ones that colonize their skin.
When a baby gets this ill, and it must make the baby very ill, the effects on the families have got to be devastating.
So I think babies that land up in hospitals, typically they are born with certain problems. And in our setting, they're often premature babies, so they've been born really early. This is all very difficult for parents to accept. And then on top of that, they now have these really severe infections. They often land up in ICU. They need drips. They might be on a machine to help them to breathe. So I think in itself, just having a premature baby, you are usually living in the hospital for many months before they actually go home. And these are just things on top of it that make it even more difficult.
And explain why the problem is so much worse in low and middle income countries like South Africa.
Yes, so antimicrobial resistance, we all now know that it is very important worldwide, but we do know that in low and middle income countries, it causes more death. And part of that is because of the less resources that low and middle income countries have. So we may not have access to diagnostics, we may not have access to some antibiotics, and staff ratio per patient may be a lot less than you see commonly in high income countries. So babies, often the wards are full, so babies might be pushed close together, and those circumstances all make it far easier for bugs to spread from one baby to another baby within the same area.
So when these drugs are so cheap and easy to get in most countries, and that's the thing we know about the most common antibiotics, they're very, very cheap. Why are children not getting the treatment they need?
So I think there's two problems. The one is that in some low middle income countries, I think South Africa, we are lucky that many of the drugs we do have access to. But in other African countries or countries in Asia, they may not have access even to the most simple antibiotic. And at the other end of the spectrum is that some low middle income countries wouldn't have access to some of the newer drugs that are more expensive. So in South Africa, we often have access to the drugs that we use every single day, but the drugs that are needed to treat really resistant organisms, we can sometimes struggle to get hold of.
And this is part of the problem too, right? People can't get the more advanced antibiotics, and so there's overuse of the cheap ones.
Yes, so, they carry on using the same antibiotics that are no longer working. But I think part of the problem is that certainly in some countries, we are unable to identify what is the bacteria that is causing the infection. So we can't choose a specific antibiotic that is effective against that bacteria. And that means we will be then using antibiotics that are ineffective.
It seems to be the answer would then be to just try to prevent the infections in the first place. Can vaccination help with that?
So vaccination is very important, and it is definitely one of the ways that we can prevent infection. Unfortunately, in very little babies, vaccines aren't as effective. So we know that they are effective in older babies, in adults, but in little babies, as most people will know, they don't get many vaccines when they're born, but they get vaccinated a few weeks later, so between kind of 6 and 8 weeks. So vaccines aren't that effective in little babies or neonates. But the emphasis has now been changed into vaccinating mothers. So we call it cocooning, so we protecting the little baby. And by vaccinating mothers for infections, we can make sure that they have a good response. And we know that antibodies that prevent these infections are transferred from the mother to the babies after birth, and these can help prevent infections.
Let's talk about the vaccinations that exist and what the infections are. Are there vaccines to protect the mothers against many of these antibiotic-resistant bacteria?
So not too many for resistant antibacteria, but vaccines just preventing any kind of infections are important. So some of the vaccines that certainly in South Africa we've started vaccinating our mothers for is something like pertussis, which most people will know is called whooping cough. And this typically occurs in babies at around 6 weeks of age before they've gotten their first immunization. So now by immunizing the mothers, we hope to prevent these infections in the young babies. And that will mean that we don't need to use antibiotics to treat the whooping cough in children. And by using less antibiotics, we cause less infections.
Let's get back to how this impacts the babies and their families. We know that in general, when infants are in hospital and very ill, the repercussions go on sometimes for a lifetime. Can you tell us about some of the things that happen to some of your patients?
Certainly babies that are born very small, who parents might be too scared even to touch because they look like these fragile little babies, they definitely do struggle to bond. Breastfeeding is very important in creating a diverse microbiome, and part of the problem in these very, very small babies that may not be breastfed early on, or mothers have difficulty producing breast milk, worsens the problem of the microbiome and the resistant organisms. And we know that breastfeeding is a wonderful way of bonding with your child. And unfortunately, these very little babies and very sick babies often have nasogastric tubes, and they're given the milk via that. So it's all very important for bonding in children. these resistant infections often happen in children that have been admitted into hospital for a long time. So I think we've spoken a lot about neonates, and I've said, if you're born at 1 kilogram, you need to almost double your weight before you are actually ready to go home. So you can spend months in hospital, and during that time, you're always going to be at risk of getting these resistant infections. But there are other groups that also may have devastating diagnoses, something like cancer, children with leukemia. They also spend a lot of time in hospital, and that's another very vulnerable group that may be infected with one of these really resistant organisms. So these infections are then on top of a ready child that has been unwell and is in hospital. They're often in ICU. So for these parents then to have to accept these diagnoses, like we said, antibiotics are not always available. Sometimes we need to use antibiotics that are not registered in children, so we may need to use them off-label. And we need to explain all these things to parents that they understand. I think one of the most devastating parts of having a child who has this resistant bacteria is that they often are put onto what we call contact precautions. And this is specific infection control precautions to prevent other children from getting the same resistant bug. So that means that anybody who looks after your child may be wearing gloves, a mask, an apron, and this can all be really quite scary for mothers and for children that can understand that. But they're often sometimes alone in a room on their own. As I've mentioned before, we have less staff than in high-income countries. So sometimes children are in a room on their own with no one keeping them company. And I think part of this is really the saddest thing for me, is that these children, don't have the stimulation that they deserve. So we've got a little baby in our ward at the moment who, like I said, is colonized with this infection. I think the difference also in low middle income countries is that parents may not be able to stay with their children all the time. They may not be able to come in and out of the hospital frequently as well. So at the moment we have a baby who has been in hospital for a few months now, I think. She's actually a little toddler, but unfortunately she is in a room on her own. And I know we just discussed this morning, it would be so nice to get her out into the rest of, into one of the bigger rooms. But because she's colonized, we cannot move her out.
Tell us how that changes her behavior. I mean, toddlers, their entire lives are being around other people. How is her behavior different?
I think she's become very quiet. She kind of sits and looks through the window all the time, waiting for us to kind of walk past or visit on a ward round. And once we are in the room, I think she's really is craving that attention. So she will very quickly come to you, try and get you to hold her, which we know that in toddlers, they to be scared of strangers. But she quickly tries to get that comfort from us.
Can her family come in and hold her and cuddle her?
Yes, so unfortunately her mother doesn't necessarily have the resources to come in and out, but we do allow parents to stay within the room with them, so if their parents are available. As much as parents like to be with their child, again, being in a room on your own, just with your child for most of the day and not necessarily being able to move around between rooms is also difficult for parents.
When you say the mother doesn't have the resources to come in and out, what does that mean? Does she live distantly?
So she doesn't live too far away, but, if you're unemployed and you're living on social grants, being able to get a taxi and come in and visit regularly is difficult. Often our parents stay in the hospital for long periods of time, sleeping in a chair next to the child's bed. But there are some parents that are not able to come in. They may be working. They don't have enough money to come in regularly. Being a big tertiary hospital, we actually see children from far distances as well. So the parents may not be able to come in. And sometimes they really do need to go home as well, the parents, for their own mental health, just to have that time on their own.
Heather, how difficult is it to help patients and their parents understand what's happening to them?
So perhaps one of the biggest problems, I think, certainly for me, is that some parents and some children actually may not be able to understand some of the doctors in a hospital. So certainly, and this is a legacy of South Africa, I may not speak the language that the mother speaks. so usually related to African languages. So I think this actually makes it worse, is that me speaking to a 3-year-old can be quite difficult to explain that. So we often need translators. I think it's certainly getting a lot better, but that definitely does kind of make the situation a lot more difficult. But yeah, I mean, if you tell the child that they can't leave the room because they have this infection, it is really difficult. And it's at one stage they might actually feel quite well. They've had the infection before, but we know that it's still on their body, and we're trying to prevent other children that would be vulnerable to get these infections. I've spoken about the different staffing ratios for patients, and fortunately many of our mothers do stay with our patients to look after them. But one of the things is that mothers that maybe stay in there and there's a baby that doesn't have a mother, they are all really helpful in looking after that baby as well. And it's something that sometimes we have to kind of chat to the whole group in that ward. So we might have 6 beds to say, we really appreciate you trying to help these other children. But it is very important that you all just look after your own baby to make sure that you wash your hands if you do touch anything else, because you may spread these resistant bacteria or other infections to other babies. So it is, any mother that sees a child crying would want to go console it. So sometimes we do have to explain to them.
Heather, thank you so much for joining us.
Thanks, Maggie. It's been great speaking to you.
Listeners, if you enjoyed this podcast, please share it. You can find links to this episode and other important topics at onehealthtrust.org. And let us know what else you'd like to hear about at owh@onehealthtrust.org. Thanks for listening.
Thank you for listening to One World, One Health, brought to you by the One Health Trust. I'm Ramanan Lakshminarayan, founder and president of the One Health Trust. You can subscribe to One World, One Health on Spotify, Apple Podcasts, or wherever you listen to podcasts. Follow us on social media at One Health Trust, one word, for updates on One World, One Health and the latest in research on One Health issues like drug resistance, disease spillovers, and the social determinants of health. Finally, please do consider donating to the One Health Trust to support this podcast and other initiatives and research that help us promote health and well-being worldwide. Until next time.